everybody, and welcome to the webinar. This is Dr. Krista Burns from the American Posture Institute, and it's such a pleasure to be joining you for a live webinar. Today, we're going to be talking about postural neurology. And thank you for joining me actually in my hotel room. I'm in Miami Beach, Florida. We're on a 5-week speaking tour in the US. So thanks for joining me live in my hotel room. Anyways, today we're going to be talking about postural neurology, and more specifically, we're going to be talking about the sensory cortex and the motor cortex. And we're going to discuss how you can understand that information, how you can understand the neurology controlling the posture system to have better outcomes, because the more specific inputs we have to the system, the better outputs we have to the system. So if you guys, as you're logging on, let us know where you're from, where you're watching today. We have Tammy from Cedar Falls, Iowa. We always love to see where our participants are coming in from. We had a lot of people register for the webinar, so we're really excited. And just so you guys know, we are going to do a live Q&A session at the end. If you have any questions throughout the webinar, you can type them along the side. If somehow I miss it, then I will address all questions at the end. All right, so we got Renee from Louisiana. We got John from Colorado. We're actually headed to Louisiana in a week or so. I'm excited. We're going to go to New Orleans, so that'll be a lot of fun. Yeah, thanks, guys, for joining us for the webinar. Again, as you're logging on, let us know where you're from, what's your name, where you're from. Also, let us know if you're a CPE or a certified posture expert. We always love when our crew joins us. And we've got Jason from Davenport, Iowa, and Johnny from Charlotte. Jason, are you a Palmer student? I graduated from Palmer College of Chiropractic in Davenport, Iowa. Got a great education there. It was a lot of fun. So yeah, thanks again, guys, for joining us. We're going to get into the meat potatoes of the webinar here in just a second. If you want to let us know where you're from, give us a shout out on social media, and we will get to with the valuable information regarding postural neurology. Just one second here. All right, we got, yep, Jason, you're a Palmer student. Very cool. I hope everything's going really well with your studies. Good luck with it. We've got Tulia from Chicago. We've got Sarah from Montana. A webinar. All right, so let's get started. And again, if you guys have any questions, feel free to type them in on the side. If I miss them as I'm going, don't worry, I will address all questions at the end of the webinar. So today we're talking most specifically about the sensory and the motor cortex in relation to postural neurology. So to begin, I pose this question to you. Did you know that 60% of patients are dropping out of postural rehabilitation, and of these 60% of patients are dropping out of postural rehabilitation, and of the entire population, only 8.4% of people are actually the manual therapist. So manual therapists see 8.4% of the population, of which 60% tend to drop out of postural rehabilitation before the expected finish date. Crazy statistic demonstrating that not only are we not seeing a huge amount of the population as manual therapists, if you are a manual therapist, but in addition to that, 60% of patients are dropping off care before we want them to. Not only are they not getting the results that we want them to, because we understand that when we make a treatment plan, we expect them to follow that treatment plan completely in order to get optimized results. However, when the patient drops off, which 60% are doing before the end of the treatment plan, the patient isn't getting the results. And of course, that's not very good for our retention within our offices. So what the research is telling us, to improve that retention statistic, the patients want to see immediate changes on every visit. Your ability with postural neurology to make immediate, precise changes that the patient can see and feel, and how relevant and powerful that is for the patient, because when they come to your office, every time they come in, they're seeing and feeling changes that happen to the posture system. Then when we understand the neurology, we understand how to help the patient keep these changes longer, and how to implement this into our brain-based postural correction rehabilitation strategies so the patient can make neuroplastic changes of the posture system in and outside of the office. Okay, so today we're going to all right, I'd be having a technical error. Can you guys just type Y on the side if you can hear me? Okay, we're good. Perfect. I just want to, we'll keep going with the information. Sorry about that. Technology is great when it works, right? Okay. So, Institute, we have what's called the eye spine vestibular model for correction. So in terms of postural neurology, we focus on three main aspects of your neurology, of your patient's neurology, which is the eyes, the spine, and the vestibular system. So eyes are our visual system, and that's how we orient ourselves within space. And the spine, of course, the physical spine itself, but what's really cool about the spine is it's not just the shape of the spine that we're concerned with when it comes to posture. The spine represents sensorimotor integration, because the spine is going to be the freeway, or the road, the pathway in which all pathways for efferent and afferent input go from the peripheral nervous system, from the body up to the brain, or also down from the brain to the body. So we have integration of sensory and motor information from the peripheral nervous system to and from the central nervous system. So that's why the spine is so important. In addition to that, we talk a lot about the vestibular system. System is so important because it controls balance, coordination, upright extension. So we talk a lot about it at the American Posture Institute that the majority of the things that we do as a society are flexor dominant, meaning that we're being pulled down with gravity into flexor dominance. So upright extension then is going to be the opposite of flexor dominance, and that's exactly what we want to achieve with postural correction, is upright extension. So when we're working with the patient, we follow this model of correction, eye, spine, and vestibular. Now, today, we're going to be talking most specifically about the spine, which is sensory motor integration. And we're going to look at that from a brain-based level and then understand how it relates to the posture system overall. Sensory motor integration, then, is going to be proper inputs sent from the peripheral to the brain, proper processing of those inputs, and then making a proper output in response to it. So we have of particular importance to our discussion today, the sensory and the motor cortex. So I'm just going to show you guys this, this brain here. So in the frontal lobe, here in the front, on bilaterally, we have the motor cortex. And then here on the side, in the parietal lobe, we have the sensory cortex. So again, the frontal lobe, we have the motor cortex, and then here on the parietal lobe, we have the sensory cortex. Now, these cortexes are responsible for how we do everything within our environment. So the sensory cortex specifically is how we perceive our environment. It's how we feel human touch and tactile stimulation. It's how we respond to hot and cold, how we respond to pain, how we understand and process all of the stimuli within our world. Okay, so all of that information then is sent from the peripheral nervous system, and it's sent via the dorsal columns, the spinal thalamic tracts, those are some important ones, up to the sensory cortex, which is right here in the parietal lobe. Now, the sensory cortex makes sense of the information that is received, and then it communicates with the motor cortex to produce a response. So a response then is going to take place in the motor cortex, which is in your frontal lobe. Now, the motor cortex is really important for all voluntary movement. So every time you want to make a movement, even the seemingly small movements that we make throughout our daily lives, me moving my hands right now on the webinar, if I'm thirsty and I want to grab a cup of water for a drink, a simple task to do, but it all starts with a brain input in order to have a motor output. So the brain, the motor cortex, tells your body to make a movement. Now, what's interesting about sensory and motor integration is that those are contralateral systems. So if I have a sensation on my right hand, that is perceived in my left somatosensory cortex in the parietal lobe. Now, if I want to move this hand, that starts with a motor output from the contralateral motor cortex. So if I want to move my right hand, the left motor cortex sends a message through the corticospinal tract, and that's going to descend, crossing the medulla, or decussate is the word we all learned at school, right? And then it's going to descend to the point of where I can make a movement with this hand. So sensory and motor are going to be contralateral pathways for voluntary movements. Simultaneously, as we're making movements, we also stabilize ourselves in space, because if I were to reach for something without stabilizing the ipsilateral side of my body, then I would potentially fall over. That is going to be an ipsilateral system. So voluntary movement of my right hand is initiated with my left motor cortex. Simultaneously, we're going to have ipsilateral stabilization of the left side of the body. So that's going to be ipsilateral. It's a non-voluntary system for postural stabilization. Okay, so that's the sensory cortex and that's the motor cortex. Let me just show you this picture here too, so you guys can get more of a visual in terms of color. So this is going to be the frontal, where the motor cortex is, and then we have the parietal lobe where we have the sensory cortex. Sometimes it's important to get that visual when learning neurology because we talk about a lot of big words, but if we can't understand where they are and how they apply, then we can't utilize them with our patients. So just to give you guys another visual indication. So within the sensory and within the motor cortex, we have what's called the cortical maps. So we have a couple of cortical maps. We have a sensory map and we have a motor map. And these maps are how we represent our body parts within our own brain. So for example, in the somatosensory cortex, again in the parietal lobe, it's all the parts of the body on the right side, as well as with the motor cortex. So every time I make a movement or every time I feel something, that information is sent to the parietal lobe for sensory information, for recognition of sensory information. Now, what's so important about the cortical map is the use it or lose it theory. You guys have all heard that with neurology, right? You lose it or you use it or you lose it. And that's because the cortical maps within the somatosensory cortex, within the motor cortex, are dynamic, meaning that our brains are neuroplastic. They're constantly changing in response to the most important stimuli within our environment. So if you have a place in your body that you don't utilize very often or that you don't move, blurring of that map occurs and the brain sees it as being less important and are set up in a way that the places in your body that are more highly innervated have more cortical representation in your brain. So for example, my hands, they're not the largest part of my body anatomically speaking. For example, my legs are much longer, much more powerful as well. But I utilize my hands a lot because of my upright postural design and the fact that I have thumbs, which separates us from other animals within the animal kingdom. We have a lot of dexterity and we utilize our hands when we're doing a lot of different movements and work. So we utilize our hands a lot, meaning that our hands have a large amount of representation within the sensory and the motor homunculus, or those cortical maps. So your feet, your face, your lips, those are all highly innervated areas, so they're going to have more representation within the map. Again, every time I use my right hand, I'm getting a message to my left somatosensory cortex map. A movement is taking place. There was a change in joint position, which is going to be the dorsal column sending that message up to the sensory cortex. Now, or lose it, the more I utilize a part of my body and work it out and train it, the more highly designed it becomes. So if I do not utilize a part of my body, it starts to blur together in my cortical map because it's not important for the brain. So the brain is like a battlefield in the sense that if you're thinking of a battle, you're going to utilize all of your resources towards the most important aspects of the battle. Does that make sense? So your brain is constantly focused on survival, and it's going to dedicate its resources to the most important aspects of you, your body, within the environment in which you live. In the sense that if I have an injury, for example, if I have a patient who has low back pain, does anybody have a patient that has low back pain? I'm sure we get a lot of those in our offices. So when you have low back pain, when the patient has low back pain, what do? They change their postural positioning around that injury, in the sense that if it hurts every time I'm seated in extension, I'm going to go into flexion to offload that pressure. That's just one example. There's all kinds of examples that low back pain patients do. They change their gait patterns. They change their postural patterns dynamically and statically. Now, when they change those patterns, they stop utilizing certain aspects of their spine. So for example, if I'm putting more pressure and more SI joints to offload my lumbar spine, then I start to have blurring up of the precise low back joints. Okay, so for example, L1 through L5. Now, then as a brain-based postural postural neurologist, I need to understand that connection and recognize that if a patient comes in with low back pain in a certain area, they likely have not been utilizing that aspect in a long time, meaning that the sensory information going to the somatosensory cortex is going to be decreased. also meaning that there's going to be more blurring of the map in that area. Use it or lose it. So recognize that neuroplastic changes have then taken place that represent lack of movement within my lower back. So in order to make neuroplastic changes to change pain patterns, as well as to have complete recovery from the injury or from the chronic pain pattern, then we need to change the brain, not just the spine. So in order to change the brain, we need to add a lot of stimulus to the area that has not been utilized. The more stimulus that we add, the more cortical representation we maintain within our cortical map. Lose it. Another example, and this is a research study, so it's not something that's necessarily something you would do in practice by any means, but I just want to explain that concept a little bit further. So what they showed through research is with a monkey, they actually cut out one of their middle fingers. Okay, so they cut out the middle finger, meaning that this area within the cortical map was blurred together. The monkey was no longer utilizing that middle finger, so the brain didn't see it as important. So there was blurring of the cortical map. So every time that the patient moved this finger or this finger, then there was actually representation of the cortical map via MRI where that middle finger used to be, meaning that the outside fingers blurred together with the cortical map of where the middle finger used to be. Because remember, if the finger was cut off, it's no longer important to the brain. We're no longer utilizing it in space. We're no longer utilizing it to survive within our environment. The brain sees it as unimportant, so the brain starts blurring together representation for the other fingers around it that are constantly being utilized and stimulated. So that's an example, of course, just to understand the concept. So again, with injuries, that's how it relates to our patients. So another common example, if I have a sprained wrist and the patient goes to the doctor and they get put in a cast. Well, in a cast, they're not moving the joints or the muscles at all, meaning that that can have neuroplastic changes. The brain no longer sees it as being important because there's no movement or stimulation happening in that area. So the cortical representation then is going to be decreased of that body part in space. So when they take the cast off, recognize that the patient then needs to do full brain-based posture rehabilitation to regain that plasticity of the cortical map, because the brain's going to see it as unimportant because it hasn't been utilized or moved. So recognize those limitations when doing rehabilitation, and be sure to set up your rehabilitation in a way that allows for that neuroplasticity to take place. This is not a one and done strategy. This is an over time brain-based postural correction strategy to change those cortical maps. Now we see a lot less, patients with a wrist sprain, for example, in our office, but apply that example to any of your patients that walk in. Again, the low back pain patients, a patient with sciatica. Patients with sciatica, obviously pain in the lower back that goes down the leg, what they found is that patients with sciatica, that the blurring of the map started happening at the hips and the legs. So the part of the back that they were not utilizing started to blur together. So how does that affect motor outputs then? So we have sensory inputs and we have motor outputs, ascending and descending information. The more specific sensory inputs that we have, the more precise motor outputs that we can produce. So the motor cortex then also has a cortical map. So the more often you utilize a joint, precise you can be with your movements, and the more representation that you have within the motor cortex. Now, our goal with brain-based postural rehabilitation then is going to be, again, to recognize the brain as being dynamic and neuroplastic, and the fact that we can provide specific inputs and create our treatment plans in a way that are complex, because the brain craves complexity. So in terms of complexity, if I'm doing rehabilitation, my bicep, for example, if I start doing a bunch of repetitive exercises in my bicep, my brain doesn't really have to pay attention to that. And this is a uniplanar exercise. So it's really easy for me to do. Even if I have a heavy weight, it's still easy for me to perform this movement. It doesn't require a lot of focused attention. So the second that I don't have focused attention, my brain switches off in terms of neuroplasticity. And sure, I may be developing the muscle, but I'm not actually changing the brain. Now, with our patients, if we want to change their pain patterns and make neuroplastic changes of their posture system, change the brain. So think about that. If there's no neuroplasticity of the cortical map happening by doing repetitive exercises that are uniplanar, what's the solution? Well, the brain craves complexity. So we want to do complex dynamic movements that go across multi planes within space. Okay, so for example, doing figure eights are going to be really important, or you can do long-term contractions. A ton of bicep curls for like this, for example, then you could do one curl that you hold, or maybe you even add muscles e-stim to have an increased contraction of that area. So you want to hold the contraction for 30 seconds to a minute and really stimulate the system. While doing that, you also want to think about what you're doing, because the second that your mind goes blank and you start worrying about other things, then you're not focused on the exercise. Your ability to stay focused, or more importantly, your patient's ability to stay focused on what they're doing within their rehabilitation, is going to increase their ability to make neuroplastic changes of the motor cortex. Be fundamental if we want to make long-term postural correction changes. So let me just review that a little bit. With the motor cortex, again, it's use it or lose it. We want to be utilizing the parts of our body through movement. And with movement, we're talking complex dynamic movements, not just repetitive uniplanar movements. Because the things that we do all the time, we get really good at, and the brain starts ignoring the parts of the body that we don't utilize. So for example, if I'm a sedentary patient, if I'm a typical occupational athlete or a desk-lete, I'm really good at sitting, used to sitting. Okay, but what it does is it starts ignoring the parts of the body that we're not utilizing. Patient, then I need to recognize that I need to start utilizing the parts of my body that I'm not typically utilizing with my activities of daily living. So again, when you start doing that with your posture rehabilitation, think about the fact that the brain craves complexity. So don't tell them to do a million repetitions of just these uniplanar exercises. Create dynamic movement patterns for the patient that they can implement within their current exercise programs, or within their rehabilitation programs if they're not currently engaging in exercise, that are going to stimulate the brain, become important to the brain, novel concepts of the brain, so that they can really engage in that neuroplasticity that could be taking place within the motor cortex and the sensory cortex. Use it or lose it. Now, how can we determine if there's weakness or deficits of the sensory system or the motor system? That's going to be an important distinction for us, so that we know how to set up our brain-based postural rehabilitation treatment plans. So first of all, within the sensory cortex, we have a couple of very important pathways. Most specifically for posture patients, we have the dorsal columns for joint proprioception. Hey, Victor from Ireland, I see you just logged on the webinar. Good to see you. So we're talking about sensory-motor integration right now. And so the sensory pathways that are particularly of importance for posture practitioners are going to be the dorsal columns, which understand and carry information about joint proprioception. So every time I move a joint in space, so I'm doing movements, I'm moving my joints, or if I do an adjustment of the spine, or a manipulation of an external or of a distal joint, it's going to send information about a change in joint position to the contralateral somatosensory cortex. The dorsal columns are really important, and how we check for deficits of that system is going to be checking joint position. So for example, does the patient understand if their finger is up or down? Checking that joint position, do they understand where their body is in space? Also checking touch, that's going to be another thing. So for light touch, for example, if you have like a pen tip, or yeah, we'll just go with this for right now because I don't have my tools with me. You have the patient close their eyes, and you're going to add and say, does this feel like this? Does this feel the same as this? Does this feel the same as this? On the upper and the lower part of the body. And if there's any changes in that sensory input, then we know that the contralateral cortex has a brain deficit, or has less ability to recognize the stimulus. It's a dysfunctional recognition pattern. So recognize that if I have decreased light touch recognition of my left hand, then that's going to be my right somatosensory cortex that has the dysfunction. So that's how you check for any changes of the sensory cortex that are going to be important for us to recognize, so that we can rehabilitate. And then with the motor system, we have multiple different pathways, both for voluntary movement and involuntary movements. So involuntary movement is going to be involuntary movement is going to be postural stabilization, because your posture muscles are dedicated to endurance, and they're going to be involuntary, versus a voluntary motion is, I want to grab a glass of water, so I make a motor command from my left motor cortex to my right hand that reaches forward to grab that water. Simultaneously, we have stabilization of the left side of the body, which is an involuntary pathway. Voluntary movement, then the most important tracts are going to be the corticospinal tract. And I think when we're talking about tracts, it's not so important to remember the names of them, although the names are useful in the sense that they tell you where they go. So corticospinal is cortex to spine, meaning that from the cortex, we have a message down the spine to the end organ that produces a movement. Postural tone and postural stabilization, which is an ipsilateral system, we have a couple of important tracts. I'll just review the names. It's more important to understand the concept of them. So we have the MLF, which descends from the brainstem down to the cervical spine to control head posture. And we have the reticulospinal tract, which descends also from the brainstem, from the pontomedullary reticular formation down to the spine, so reticulospinal, and that's going to inhibit flexion. So again, flexor dominance is here, rolled shoulders, anterior chest flexion, forward head posture. Now, in order to resist that, to resist flexion, that's going to be sensorimotor integration from the reticulospinal tract. Also, we have the vestibulospinal tract, vestibular system to spine, and that's going to stimulate extension. So we want to produce flexor-extensor synergy in the sense that we're inhibiting flexion. So we go from here to here, we're inhibiting flexion, or activating extension to keep the body upright against gravity. So again, for voluntary movement, we have the corticospinal tract, which is going to be a contralateral system. And then for the posture system, we have ipsilateral tracts, which are going to be the MLF, the reticulospinal, and the vestibulospinal tracts. So how can you check for weakness of the motor cortex? So weakness of the motor cortex, then you can see multiple different fashions. A really simple way that a lot of you are probably already doing, but maybe you haven't made the connection that it's actually a brain test, is going to be muscle tests. So if I hold my hand out here and I'm testing my deltoid, for example, and we push down and I go weak, that's an indication that the contralateral motor cortex did not send the appropriate amount of information to hold the muscle contraction. Okay, so it's not just of the localized muscle, it's also a test of the brain output to that muscle for the ability to stabilize and hold that contraction. So for example, if you do a motor test, you're testing the voluntary system on the contralateral side of the body. Okay, or excuse me, contralateral motor cortex. So that's a really simple way to implement into your tests that you're already doing, because a lot of you are probably already doing muscle tests. You guys can actually type Y in the side there if you're doing muscle tests already in practice. I'm curious to see who's already doing that, and if you were doing it more so from a muscular perspective or from a brain perspective. Also evaluate for motor output by checking gait. Is such a good analysis tool to utilize. Now, when doing gait, it is better if you can record it, because then you can see more specifically what's happening versus in real-time gait patterns, because they're much faster. If you record it, you're able to analyze more specifically what's happening with our gait patterns. But nonetheless, if you don't have that technology right now, if you don't want to do a little video on your iPhone, for example, at least watch the patients walk within your office. Have them walk back and forth a couple of times. So most specifically with motor output, what are you watching for with gait patterns? You're checking for arm swing. So if you notice that as the patient's walking, they're only swinging one arm and the other arm is really stationary, it's not moving, that's going to be an indication of decreased motor output of the frontal lobe. So decreased motor output from the motor cortex. A couple of you guys are doing motor tests. That's awesome. Great. So now you can implement it from a brain-based perspective, not just from the segmental muscle. So as you're watching gait patterns, then check for arm swing. So in addition to everything you're already checking for, you're checking for pronation, supination, you're checking for position of the hips, you're checking for postural patterns, dynamic postural patterns. In addition to that, check for arm swing, because arm swing, if they have a decreased arm swing on one side, it's going to indicate that the patient has decreased motor output from the contralateral motor cortex. going to be really important information for us in deciphering which motor cortex we want to work with our posture rehabilitation programs. And you can easily recheck that on patients too. So you can neurology and postural neurology is that every time that you perform a stimulus, whether it's a manipulation, an adjustment, a stimulation, a movement, whatever you choose to do with your patient on that visit, you can instantly recheck. And I mentioned at the beginning of the webinar that patients want to see instantaneous changes. It's our human nature. In this day and age, we want everything 5 minutes ago. So especially if a patient is in pain, they want to see changes that are happening within their body instantaneously. And you can see that with the application of postural neurology. So I say that because it's really good for your feedback as a practitioner, because if you see a change take place, you know that what you're doing is a proper stimulus and to keep doing it. It's good dynamic feedback for you, the practitioner. In addition to that, from a practice growth perspective, or from a practice management perspective, every time a patient can see and feel changes happening in their body, it's spot on for your communication to them. It eliminates the fact that you're just talking at the patient, telling them that they're improving. They're actually seeing those changes take place. So that's just kind of a practice management tip right there. So we know how to check for deficits. Again, for the sensory tracts, we're going to check for joint position. Now, I mentioned with joint position, you can go up and down with the finger, have the patient close their eyes and tell you if it's up or down. You can also do digit distinction. Digit distinction is going to be kind of a fun test. You're going to be shocked when you start doing this with your patients, because they're going to recognize that they actually have a lot more decreased proprioception than they anticipated. So you have the patient hold their hand out like this. They're going to close their eyes, and you're going to tell them these instructions. You're going to say, I'm going to touch your fingers. As I do, you're going to tell me how many fingers are in between the fingers that I touched. So for example, if I go like this, it's 0. If I go like this, it's 1. If I go like this, it's 2. Can you guys see that? So you're telling the patient that, and you're doing that with the eyes open. Now, it's going to be a quick touch with 2 hands. So I'm using 1 hand because clearly I can't use 2 hands at the same time. So you touch quickly like this, and you ask the patient how many fingers are in between the 2 fingers that I touched. Now, this is going to be a recognition of proprioception. It's going to be a recognition of their body in space. So you touch and they respond. Now, if they get those incorrect, then it's an indication that there's a decreased sensory input. There's a decrease in recognition of the sensory input to the contralateral somatosensory cortex. Always do this about 5 times on each hand. It'll only take you about 30 seconds. Also on the feet, excuse me. So 5 times on each hand, but also on the feet. Now, the reason that this is so important is because it shows to them that they have, well, one, it shows to you, the practitioner, if they have a decrease in somatosensory input processing, but also it shows to the patient, wow, I really do have a problem with proprioception. I didn't realize that. We should know where our fingers and our fingers, our hands, and our toes are in space. That should be something that's very easy to understand. However, when we have chronic injuries or chronic postural distortion patterns or changes in our postural alignment, that proprioception is then altered. And with that altering, we have changes in the brain which are unfavorable. Favorable changes of the somatosensory cortex are going to be demonstrated with joint proprioception, with digit distinction like we just talked about, with light touch differentiation. Feel like this? Does this feel the same as this? And if there's a change in that sensory perception, it's going to be an indication that you need to work that part of the system to develop positive neuroplastic changes. Okay, so that's the somatosensory cortex. Again, I'll review quickly the motor cortex. So motor output, one of the easiest way to check it, well, 2 simple ways that you can check it if you're not already doing this already. I know a couple of you guys. We got Brian. Couple of you guys. Brian for sure is doing this already in his office. And announce your name, Sloban. You guys are already doing this in your office. So you're checking motor tests. You're checking voluntary motor tests. And when you're doing this too, recognize that it's not you versus them. So sometimes when you're checking motor tests, you add a bunch of pressure to the patient and they go weak. Why is that a faulty test? Because you're checking the patient's right to left. You're not checking your strength versus their strength. So when you're doing a muscle test, and a lot of you guys already know how to do this, just a reminder, you tell the patient, if you're pressing down on the arm, you tell the patient to press up into your hand. So they press up, and then you match their strength by pressing down. You're not adding a bunch of pressure before they even contract and pressing down. If you do, you're going to get some false negative findings. So it'll be an inaccurate representation from the right to the left. So you're checking for changes in motor output from the right to the left, checking for weakness specifically of the voluntary motor system. tract. Then in addition to that, you're going to check gait patterns. And as the patient's walking, you're specifically looking at their arms for the motor cortex. You're checking a lot of things biomechanically, but from a neurologic perspective, check the arms for arm swing. If there's lack of arm swing, that tells you, it's a visual indication both for you and both for the patient, that there's lack of motor output to the contralateral arm. So if I've decreased arm swing in my right arm, that's going to be a lack of motor output from my left motor cortex, okay? Contralateral system. So we know then that we need to work the left motor cortex. And when we do, we should see an increase in strength in the motor output, and we should see an increase in arm swing. Okay, does that make sense? So how then does all of this relate to your patient? What can you do then with your postural correction treatment plans to get your patients better and keep them longer? Well, we talked about immediate changes keep patients happy, so they see improvements instantaneously. It's good feedback for you. It's good feedback for them. That's going to keep them engaged in their brain-based postural correction treatments. In addition to that, educate them about neuroplasticity. So neuroplasticity is kind of a buzzword. It's something that they've probably heard before already, but educate them of what that means. Help them understand the difference between just chasing pain patterns and changing the brain for neuroplastic changes of the posture system. So when you do that, then the patient comes in with different goals. Sure, we want to get the patient out of pain first, absolutely. But in addition to that, we want to change their brain so they can hold their postural correction better. They can make advancements in their posture system that they wouldn't be able to make in any other situation. So educate them about that. Also, recognize that pain is in the brain. So if a patient comes in who has pain, hey doc, I have low back pain, especially if it's a chronic presentation of pain, recognize that that's an interpretation of the brain. So you don't actually feel pain. This is kind of a crazy concept, but you don't actually feel pain in your body in the periphery. You actually perceive your perception of pain within the brain. So recognize and tell the patient, don't tell them, pain's in your head. They might take that incorrectly, but educate them that pain is, it's an output. It's a perception in the brain. And if we want to make changes to your pain, then we need to make neuroplastic changes of the brain. And also, if they're out of pain at that point, then recognizing and educating the patient about making those neuroplastic changes with continued postural rehabilitation so that we can then prevent that common faulty pain pattern from coming back. So make that connection with your patient, make that neurologic connection so that they can understand the importance of prolonged and sticking with their original treatment plan in terms of postural correction. And of course, we don't want to ignore the brain. So a lot of systems out there are not taken into consideration and the impact that the brain has in correcting our postural design. So I want you guys to recognize that impact. You learned a lot today about the sensory and the motor cortex, which are so important for postural design. So with that being said, I just wanted to open it up for a live Q&A. If you guys have any specific questions of what I've just mentioned, please let me know now, because when it comes to information, it's only as valuable as the application. So I want to make sure this information was clear. None of it went over your head. If you missed something, let me know. And then you guys can actually apply it within your treatment plans. So specifically to do rehabilitation of the motor cortex, you want to think of doing complex movements, like I mentioned. So instead of just doing a bicep curl, think about doing figure eights and dynamic movements. Have the patient focus on the exercise, because when they have focused attention to the exercise, they're creating that neuroplasticity. Also for the sensory cortex, use it or lose it. You got to move the joints in order to build that cortical map. In addition to that, some other great sensory inputs that you can think about utilizing with your patients, depending upon the flow of your office, is whole body vibration, specific handheld vibration in areas that lack sensory input. You can also do posture taping. That one's really good. It's not as strong of an input as an adjustment, for example, or of a movement in an exercise, but what it is it's a continual stimulus. So the patient leaves your office with a stimulus on tape. So those are all examples that you can utilize to develop the sensory cortex, to develop the cortical map. For the motor system, again, doing strong isometric contractions, utilizing E-stim, doing movements that the brain craves versus doing repetitive uniplanar exercises. Okay? All right, guys, if you have any questions, go ahead and type them in the side. I'm more than happy to answer them. And in the meantime, that is information again with your rehabilitation plan. So structure your exercises and your corrective protocols around the patient's ability to have neuroplastic changes. About getting them in one and done. Think about changing the brain to change pain patterns and have long-term postural correction. Says, are you going to have a replay of this video? Yeah, the replays are being emailed out. So if you have any questions or if you missed some of the information, it will be emailed out. Absolutely. And if you have any specific questions right now, I'm more than happy to get those answered. Yeah, it looks like Dr. Mark is the email will be sent out in just a few hours. So you guys can catch that replay. We're more than happy to do it. So again, with postural neurology, what I think holds a lot of people back from implementing postural neurology into their office is they think that it has to be so complex, or they think that the information's over their head. Neurology is just a bunch of big words that I memorized in school. I don't actually know how to apply it. Well, our goal is at the American Posture Institute with the Postural Neurology program is to help you make those connections that maybe you never made in school. So sure, you memorized a bunch of tracks to pass a test, but how do those tracks relate to your everyday patient? What does that mean for the patient who walks in with low back pain? If we have a patient with low back pain, likely they have decreased proprioception, which is the dorsal columns that's affecting the proprioception of the lower back because they've had an injury and they never had proper brain-based posture rehabilitation to rehabilitate that area. And then recognizing that motor output is going to be a combination of stabilization, which is involuntary, as well as motor output, which is going to be the cortical spinal tract. So understand that the utilization of these pathways is for our benefit as practitioners. Sensory motor integration is so important for making neuroplastic changes in the posture system. Okay, we have a question here. Multiplanar exercises in the pain-free range. Great question. So when doing complex movements, multiplanar exercises, would you do it in the pain-free range? And that's a really good question because you want to keep them within the pain-free range, but you want to keep it complex and focused. So for example, you want to bring the patient just to the point of neural fatigue, because if we don't bring them to that point, they're not going to make changes. But with that being said, you don't want to create a massive amount of pain for the patient. So bring them to the point where you start to see a breakdown in the system. For example, if you start seeing postural changes, if you have the patient doing figure eights and they start stabilizing their body like this to do the figure eight, that means that they're in pain and they're past that point of neural fatigue. So we want to bring them back just a slight touch to stay within that pain-free range of motion, but to still be activating the system to make those neuroplastic changes. Dr. Mark was just mentioning mirror imaging or opposing joints. So what that concept means is that because of cross-cord patterning, if you have knee pain, for example. So if your patient comes in with a right knee pain, you can actually, if it's really painful for the patient to be working out their right knee, then recognize that limitation, but still recognize the ability to make a change. So you can actually work with the left opposing joint, which is going to be your left elbow, for example. So you can do rehabilitation on the left elbow, and that's going to have an effect on your knee. But you have to be a little bit specific in the sense that recognize that if the patient has pain with knee flexion, then you want to do flexion of the opposite joint. Okay, so in terms of opposing joints, we have ankles and wrists, we have knees and elbows, we have the hips and the shoulders. Okay, so that's another way of approaching it that maybe you haven't done in the past that can be effective if the patient's in a lot of pain, especially with an acute presentation. That's going to be one of those things that you can implement right away that they're going to feel benefit from, but they didn't necessarily have to put themselves in pain in order to feel that benefit. Move the other body parts. Cortex. Okay, so Dr. Mark is mentioning that you can also activate that side of the body. So for example, if with doing certain movements, I can still work the motor cortex by not utilizing that exact part of the body. Or you can do passive stimuli. So you can still block pain patterns by adding passive stimuli. It is better to do complex motor patterns because it's going to create more neuroplasticity. But if the patient can't get there because they're in too much pain right now, recognize a regression, which could be a passive therapy. where you're actually moving the joint for the patient. And then eventually they get to the point where they can move it themselves. That's going to override the pain pattern, the stimuli going to the brain. Okay, so recognize there's multiple different ways to take care of a patient. Recognize what's going to be the best for the patient in your office that day. And I appreciate that question, because I was saying, you want to ramp up the system, you want to do hardcore isometrics, you want to do complex movements. And I appreciate you asking that question, because with every patient, they're going to have different needs and different levels of postural fitness that day they come in the office. So if the patient physically can't get there because they have a lot of pain, then a way of blocking that pain signal or getting movement into the joint without bringing them into too much pain can be passive movements, where the doctor actually moves the joint into that space for the patient. Do you guys have any other questions? Feel free to type them in the side there. Oh, okay, another question. So I've been living with chronic pain for the last 12 years from an accident. No one I've gone to for help and healing has explained this level. Oh, actually, it's a comment. It says, thank you for your help. You're very welcome. I'm glad that you found the information to be useful. And do recognize that with chronic pain patients, that you need to keep them in the office long enough, or provide them at-home rehabilitation that's going to create neuroplastic changes, because if not, the same pain patterns are going to keep arising, just like our person here. And David says, doesn't vibration of a joint override pain signal? David, great point. Vibration is such a good stimulus to utilize. So if you don't have whole body vibration plates in your office, like we do at the American Posture Institute, you can still utilize handheld vibration. And you can even tell your patients to get handheld vibration massagers that they can utilize at home. It's $20 on Amazon, and it's really, really efficient. It's a strong stimulus to the sensory cortex that can override that pain signal. Plus, if you have decreased cortical mapping of a certain area of your body, in addition to working it out by doing complex movements, you can do complex movements on whole body vibration, or you can add handheld vibration stimulatory effect to that joint or to that muscle while you're working it out, to have a more complex, more stimulatory effect to the cortex. So thanks for bringing that up. Whole body vibration, handheld vibration is something we utilize daily at the American Posture Institute. I can't recommend it enough. It's really great for building neuroplasticity. So thanks for mentioning that. Any specific exercises you would recommend for us? So thanks for asking that question, Tyler. So specific exercises, and again, make these patient specific, but overall, patients are really going to benefit from extension exercises. So extension exercises are going to be wall posture, where they're back against the wall and they move their hips into arches and tucks against the wall. Also, are you asking specifically about SI? Okay. For the SI joint. Sorry, I read the question a little bit incorrectly. Go through some specific exercises and then go back into the SI joint. Sorry, I read that incorrectly. So overall, working the extensors is going to be really good input, because we're constantly flexor dominant. So doing extension exercises like a bridge, wall posture, Supermans are really good. Complex movements such as figure eights. So if I have decreased motor output on the right side of my body, doing figure eights, both with your wrist, with your shoulders, with your ankles, those are going to be really good, strong, complex movements. You can also utilize multiple joints at the same time. You can do balance training, which is really, really beneficial for the vestibular system. And then we have a question from Heather. What would you recommend for forward head syndrome? Posture, doing neck retractions is really good. So a neck retraction then is the patient has their head here, they're going to pull it back. If you have them standing against the wall, it's good feedback from the wall. So have the patient go forward, go back, make them hold it, because if they don't hold it, it's not going to create that strong isometric contraction that we really want in order to make changes. So they go forward, back, and hold. Here's the most common mistake that you're going to see with that exercise is the patient's going to do this type of movement. They don't have the proprioception of their neck to do full retraction, so they're going to start doing this type of movement. Tell the patient that in advance so that you can prevent it from happening. To keep their eyes level with the horizon and go straight forward and straight back like this. You can also do cervical traction, which is going to be highly beneficial for forward head posture. You can also do doctor-assisted neck retractions in the sense that you add pressure here. They're going to press up and then back against the table. And if you do this before your treatments, it's also going to be really beneficial because you're stimulating extension. Okay, so then we have question. Okay. Dr. Mark is just mentioning PMRF enhancement for forward head posture. That's a big topic, but we're going to try and cover it here in just a minute or so. So the PMRF stands for the pontomedullary reticular formation. Now, the pontomedullary reticular formation is found in the brainstem. The brainstem controls your posture. It controls your involuntary stabilization of your posture muscles. So if you have forward head posture, then it's a lack of inhibition of flexion. So I mentioned before, the reticulospinal tract is going to descend from the brainstem and inhibit flexion. So it's going to inhibit your flexor muscles, meaning that if you have forward head posture, it's a lack of inhibition, okay? Meaning it's a dysfunctional PMRF or communication of the reticulospinal system. So what can we do to override that? Well, let's understand what lives in the pontomedullary reticular formation. So within that aspect of the brainstem, we have a cluster of cranial nerve nuclei that live there. So in addition to doing biomechanical exercises to stimulate neuroplasticity, contractions, which I mentioned, you can also do activation of the cranial nerve nuclei that are within the pontomedullary reticular formation. Okay, that's a mouthful, but work with me here. So for example, we have cranial nerve 12 that controls your tongue posture. So by utilizing your tongue, it's a good stimulus to the system that then controls your posture. Same thing with the vestibular system. The vestibular nerve, the cranial nerve 8 of the vestibular system lives within the pontomedullary reticular formation. So by doing balance exercises in addition to extension exercises, those are all going to be stimulations for the pontomedullary reticular formation. And Dr. Mark is typing in the side here, extension exercises are great for PMRF stimulation. So again, if function is to inhibit flexion, if the patient has forward head posture, anterior rolling of the shoulders, that's lack of inhibition or dysfunctional pattern of the PMRF. So in order to override that, overcome that, build neuroplasticity of the posture system, we want to do extension exercises. Now I mentioned before, really good extension exercises, Supermans, where you lay on your stomach and you go into extension by lifting your hands, your head, and your feet off the floor. So extension exercises are good. Wall posture, where you have the back of your hands against the wall, your head against the wall, and you're moving your pelvis down and forward, and then up and back in that motion. That's going to be all extension exercises. Also bridge exercises, where you're laying face up, you're against the ground and your feet are against the ground and you're raising the pelvis up for activation of the glutes. That's going to be another really good extension exercise. Oh, Tammy says she needs to get back to work. Thanks for the information. You're so welcome. I understand that you guys are all really busy practitioners, so thanks for spending an hour with us today. We do appreciate you guys. Everybody who shows up for these webinars and engages in this information, I know that you guys are the ones who are really looking to up-level your knowledge and make a difference in the lives of your patients. So I appreciate all of you guys for joining us. If you have any more specific questions after watching the webinar, then be sure to just email us and let us know. We're more than happy to support in that learning process. Okay, I think I skipped David's question. Okay, sorry, David, I missed over one. So vibration of the joint and stimulation of the contralateral joint would work as well. Talking about whole body vibration and handheld vibration. So the specific question is vibration of the joint and stimulation of the contralateral joint will work as well. So if you want to work the motor cortex on the right side, then you're going to stimulate a joint on the left side. And that's going to, actually it's for the sensory cortex, not the motor cortex. So for the sensory cortex on the right side, you're going to stimulate a joint on the left side of the body, contralateral system. Now you can go directly to a joint that's dysfunctional or directly to an area of the body that demonstrated lack of sensory input. So if you did light touch and they can't feel the difference from this to this, then that's going to be a really good indication of where to apply the vibration. Overall, however, if you just want to do vibration on one side of the body, do it contralateral to the somatosensory decrease. answer that question. Vibration of the joint and stimulation of the contralateral joint will work as well. Absolutely. So in regard to vibration, do it opposite to the somatosensory deficit, so contralateral system. So if I'm trying to work my right somatosensory cortex, I could stimulate of my body with whole body vibration by standing on there with one foot, or I can get really specific in specific joints, or I can do handheld vibration, for example, of the left paraspinal musculature. All of those things are going to be stimuli. So whole body vibration, handheld vibration, can't recommend it enough. Also, movement, complex movements, dynamic movements, adjustments, manipulations of the joint. That's going to take the joint to the paraphysiologic space. It's a really, really good input to the system. So all of those things are really good benefits that you can provide to your patients. All right, docs, thanks again so much for joining us. Angela says, great webinar. Thank you. Angela, you're more than welcome. We appreciate you joining us. As I mentioned, you guys are the best of the best, the ones that show up, who listen to this information, and more importantly, go and apply it. So if you have any more questions, be sure to shoot us an email and make it a great day. Remember, it's posture by design, not by circumstance.